Welcome, friends. Today's lesson is going to be about hiatus hernia. As you know, hiatus hernia is a very common clinical condition in general surgery, and it can lead to a variety of complications and symptoms. So I'm going to stick by the basics, the very basics that you need to understand and learn at your level of education, and that's what I expect from you to know in the exams or as a junior doctor in their training. First thing that I want you to learn is a little bit about the anatomy. So I have taken the most important and relevant points to the anatomy of the hiatus hernia. We know the esophagus traverses the diaphragm in between the right and left cross. The hernia itself is a matter of usually migration of the gastroesophageal junction into the superior mediastinum via the esophageal hiatus. Now, the esophageal hiatus is lying opposite the thoracic vertebra 10 or around that. And you will see that the hiatus is surrounded by the right cross and the left cross. And the left cross here separates the esophagus from the abdominal aorta. Above that level, the green area is where the esophagus lies directly behind, the aorta lies directly behind the esophagus and only separated by some areolar connective tissue. Anterior to the hiatus, we have got the central tendon of the diaphragm. So it's a tendon composed of interlacing white collagen fibers with no actual muscles in that central part. Below the diaphragm, you could see the inferior phrenic arteries that supply the lower inferior surface of the diaphragm. When the esophagus passes through this hiatus, with it will pass both the right and left cross, and in here we will call them the anterior vagus and the posterior vagus because they change their temporal relationship to the esophagus once they exit the hiatus in the diaphragm. So you get part of, to recap on this, you get part of the stomach, which is usually the fundus, along the gastroesophageal junction that will migrate upward into the posterior mediastinum in the chest. It's important to know the types of hiatus hernia, and there are generally four types of hiatus hernia that we know about. And this is all dependent on the position of the gastroesophageal junction and what viscera have already herniated through the hiatus into the posterior mediastinum of the chest. The most common hernia that we get is we call the sliding hiatus hernia. And it's called sliding because the gastroesophageal junction migrates above the diaphragm, and the proximal part of the stomach to a variable degree will be sucked up into the chest. The size of this hernia could vary from a small one to a massive where the entire stomach could sit in the chest. The second one is called the rolling hiatus hernia, and the rolling hiatus hernia is very important to diagnose because it is the one that can lead to acute complication in the form of gastric volvulus. Now, in this situation, you will find the gastroesophageal junction still is below the level of the diaphragm, but part of the fundus of the stomach has herniated alongside the esophagus into the posterior mediastinum. Again, the size and the symptoms are very variable, depend on the extent of herniation or the size of the stomach that is in the chest. There is a third one, which is called mix, where you have both of these. You have the gastroesophageal junction with a sliding hernia that went up, and part of the fundus of the stomach rolled to the left side, and then behind, and then it goes behind the esophagus. So it really rolls around the gastroesophageal junction, and that's what can lead to strangulation of the hiatus hernia. So these two, the ones that can get volvulus or strangulation of the stomach. And the fourth one is the complex. Now, with the complex one, it's a simple sliding hiatus hernia, usually, and there will be other viscera that get pushed up into the posterior mediastinum of the chest, and these organs could be either colon or the spleen or the tail of the pancreas. They usually happen, you'll find in elderly people, long-standing hernia. A lot of them do have scoliosis and reduction of the abdominal cavity with increase in the intra-abdominal pressure. It's important to know about the causes because patients will ask you, what do you think, how did I get this problem? So you need to have an idea as to what actually has caused it. Now, we don't have a single, only definitive causative factor for hiatus hernia, but there are precipitating factors. Among them, and most important, is obesity. Obesity is always associated with increased intra-abdominal fat, and that will lead to increased intra-abdominal pressure, which will lead to the herniation when you combine that with the negative intrathoracic pressure. Age-related changes are very important because connective tissues and muscles in general get weaker with age, and probably more so in people who smoke. And what that will lead to, it will lead to widening of the hiatus by weakening the crura of the diaphragm and making the hiatus larger than its normal size. Pregnancy is a known factor for hiatus hernia. It does cause increased intra-abdominal pressure and pushes on the rest of the abdominal organs, including the stomach and the diaphragm, which will lead to a possibility of herniation. Apart from that, any reason for increased abdominal pressure, whether it is as a result of ascites or chronic cough or difficulty micturition in elderly people who have prostate, are other possibilities that could lead to aggravation of the hiatus hernia. Lots of time we found there will be mixture of these causes, more than a single factor that lead to formation of the hernia. Now, how do we find about them? What do patients present with? Typically, we have people who come in and found they have got a hiatus hernia that is incidental, which means that they were or they have been investigated for some symptoms in the abdominal cavity, or whether related or unrelated, and as a result of that, their investigation shows a hiatus hernia. Usually, that will be found easily on a CT scan. So a lot of them are incidental. The next category is people who get reflux and heartburn, where they do actually have symptoms identical to reflux, and they can be treated as such. Now, not all hiatus hernias are associated with reflux, and not all cases of reflux have hiatus hernia, so they are not exclusive of each other. You could have reflux without hiatus hernia. You could have hiatus hernia, which is incidental, asymptomatic, with no reflux. Some patients come to us and say they have got food regurgitation. They, after their meal, if they lean forward to pick something from the floor, or they pick their child, or lift them up, or at work where they have to carry heavy weight equipment or good, uh, then they feel the symptom get worse, and undigested food would come up into the esophagus and up into the mouth with excessive salivation usually. Patient could present with respiratory symptoms, particularly those who've got respiratory problems such as asthma, and regurgitation and reflux can lead to silent aspiration, which could lead to a lot of complications that vary from simple wheezes to sore throat to formation of lung abscesses. These patients typically are treated by respiratory physicians, and during the course of their treatment and investigation, they investigate them further, and they found they've got hiatus hernia, and then they send them to us to address the issue. Now, if the hernia strangulate or we get gastric volvulus, it's a sudden onset, acute upper abdominal pain radiating to the chest, and the patient is trying to vomit. Most of the time, it's very difficult to vomit, so they develop what's called dry reaching, which means that they are trying to vomit, but nothing is coming up. They have difficulty swallowing, they can't tolerate anything oral, and they present usually as such. Some of them present at later stages, and if the strangulation has been ongoing for a few days, you could end up with ischemic changes in part of the stomach, which make the problem highly comorbid, and it could be fatal. Now we go with the patients that we suspect they have hiatus hernia, or they are proved to have hiatus hernia. We need to work them up if they are symptomatic and suitable for treatment. And the first thing we will start with is endoscopy. Upper GI endoscopy. Hiatus hernia, particularly the sliding hiatus hernia, in this situation, when you look at it inside the stomach, this is a retroflexed area of the gastroesophageal junction. So the scope is retroflexed to have that view from below that will show you the gastroesophageal junction and the fundus of the stomach. And you could see here are the crura. This is where the diaphragmatic hiatus is. And we go to below the stomach and the gastroesophageal junction, fundus of the stomach and the gastroesophageal junction above the hiatus. So that's how it appears on endoscopy. So we can confirm the hernia. We need to measure the length of the esophagus in all these situations, which is the distance from the incisor teeth to the Z line. And the Z line is the line that separates the squamous mucosa that line the esophagus from the columnar epithelium that lines the stomach. Normally this could be around 38 to 42 centimeters, and we need to know that because some patients who have a large, long-standing hiatus hernia, they could get shortening of the esophagus, which has specific implications to the operation that they will need to have. We check them for Barrett's because, as we said, a lot of these patients do have reflux, and they could get Barrett's esophagus. If we see any Barrett's, we document how long it is, the length of the Barrett segment, and we take lots of biopsies from each quadrant, a biopsy to each centimeter of the length. And these biopsies will be examined under the microscope to assess them for dysplastic changes, which might alter the course of the treatment, or you could even sometimes find early cancer in the situation, which again will have would change the plan for the treatment. If there are ulcers and reflux inflammation in the lower esophagus, we assess the degree of that and we give it a grade according to what we saw in the reflux lecture. And then we go to the stomach and the duodenum, and that's mainly to exclude another synchronous pathology that could be of consequences or could be even the source of the symptoms that the patient is having. Usually when we consent and book the patient for an endoscopy, at the same time I send them to have a barium swallow. So by the time they get their endoscopy, we would have good results of the barium study to help us make a decision on the treatment. Now, barium is very useful. It will delineate the hernia for us. It will show us the size of the hernia. In addition to that, we will have a measurement of the length of the esophagus. We will see if there are any reflux changes or not, because when the patient have the barium swallow, after a short while, after assessing the motility and clearance of the esophagus, they tip the patient's head down in a reverse triangular position, and they see if there is any reflux of the contrast from the stomach back to the esophagus. And they will tell you whether it's mild, moderate, or severe. Usually these two investigations are enough in majority of the cases. Barium will give us also a bit of an idea about the motility of the esophagus, and if the esophagus is dilated with ineffective motility problem, then in that situation we will need to get manometric study to address the issue, because that could have significant impact on the decision that we will take for the treatment. The role of CT scan in hernias is mainly, in fact, is useful in patients who have suspected volvulus of the hiatus hernia of the stomach, and in that case, the treatment will be emergency and it will be different, and we will cover a bit of that at the end of this lecture. It will be in brief. Now we've got all these things. There is no cancer, there is no Barrett's, let's assume, and the patient has got reflux and symptoms. How are we going to manage them? The management, the medical management is, and in general, the management has got only few differences from the management of the reflux, because often that's what we are trying to treat, unless the hernia is very big and causing respiratory symptoms or chest discomfort without any respiratory complications, then the treatment is more or less similar. So we start with medical treatment. We often ask the patient to lift the head of their bed 6 inches at night, because the symptoms tend to be worse at night, and that can relieve the symptoms. We also put them on PPIs such as pantoprazole or esomeprazole, Nexium, and the dose is usually 20 milligrams once a day, and we see their response to that. Domperidone can be useful to enhance and improve the motility of the upper gastrointestinal tract, and is often used in this situation before operating, or those who don't want to have surgery. They need to have some modification of diet, and the offending diets that need to be excluded are chocolate and alcohol and smoking. Occasionally, coffee and tomatoes can affect these patients as well and make their symptoms worse. Often the patient will figure out these things before they come in and seek your help. We ask the patient to have small meal rather than large meals, and certain people do not tolerate spicy food or fatty food, so we try them to try and eliminate the offending agents that make their symptoms worse, and then we see them afterwards. Now, medical management might be by itself enough to manage the symptoms of the patient, and they could go for life doing the same routine medical issues that we have advised them to do. Uh, but surgery is commonly needed to control the symptoms, to reduce the hiatus hernia, and to prevent further complication. Now, repair of the hiatus hernia is known to be very effective in reducing the inflammation in the lower esophagus and also in helping the Barrett's esophagus to stop progressing to a higher degree of dysplasia and cancer. The operation that we do is repair of hiatus hernia. Usually we do it laparoscopically, and the operation involves direct laparoscopy. Then we dissect the sac of the hernia, and the sac of the hernia will be in the posterior mediastinum. The operation starts by incising the fundoesophageal ligament, which is the ligament that sits between the top part of the abdominal esophagus and the central tendon. And then we dissect the sac entirely until we get the whole stomach to sit in the abdomen where it is not pushed up again when you let go with your graspers. So you will see that if the sac is not fully dissected and you release the grasp on the stomach, it will get sucked up back into the chest. What tells us we have done or have taken the entire sac is when the stomach would stay on its own entirely in the abdomen, and also the gastroesophageal junction is below the hiatus, below the diaphragm. That's the first part. Then we do what we call Cruroplasty. So you imagine the right and left cross running parallel to each other with a wide gap in between them. So we do approximate them with non-absorbable stitches laparoscopically to narrow the hiatus, to get it to go back to its original size. It's important not to narrow that too much because it could lead to dysphagia. I regularly put a mesh, and the mesh that I use is titanium-coated polypropylene. It's called Ti-mesh. We put it on the Crura. So we make it like a U-shaped cut where the opening of the U is going around the esophagus. The main purpose of the mesh here is to reinforce the hiatal repair. So the bulk of the mesh and the white part of it will sit behind the esophagus across the right and the left cross, and it get fixed in there by staplers or sutures. Because that way the failure can happen if the crura get stretched in the future by increased intra-abdominal pressure. But the mesh will work as a scaffold for the connective tissue to lead to healing with a tough scar tissue. Now, because these patients usually have reflux, some form of fundoplication will be used, and there are few types, but the most important are the Nissen fundoplication and the toupet. What does that involve? When the esophagus is fully dissected of the crura, we'll be able to pass the grasper behind the esophagus. We grasp the fundus of the stomach. We pass the grasper behind the esophagus, grasp the stomach, esophagus, fundus, and pull it to the right side of the patient. It has to come freely with no tension. And then we could wrap it around in at 360 degrees like this, and we do sutures. It has to be short and it has to be floppy. So it's a short, floppy Nissen fundoplication is the most proven form of surgery that help to prevent reflux. Now, with the toupet operation, they just do they do it in this way. So this is the Nissen 360. In the toupet, you just pull the stomach behind the esophagus and suture it to the crura. The edge of the stomach here is sutured to the crura, and in here to the esophagus, and then here again the stomach to the esophagus. There is a risk of having dysphagia with the Nissen, and that is a lot less if you do a toupet fundoplication. the trade-off is there will be a higher chance of getting recurrence of reflux in with the two-pair fundoplication. I do this in patients who are elderly or their manometric studies and Barium showed motility problem in the esophagus. The complication that can happen from this operation is perforation of the esophagus. You could get pneumothorax and you could get recurrence of the hernia and also difficulty in swallowing. Difficulty in swallowing is the one that I encountered most, and in this situation we do dilate them, either pneumatic dilators or the flexible dilators, and we usually go up to about 50 for French in one setting. It will need to be done a few times, usually before the patient will be able to swallow. Now, the last part that I wanted you to be aware of is gastric volvulus. It's a rare clinical condition, but we see that every now and then. Mainly happens in rolling hiatus hernia. Patient will present to you with abdominal pain, unable to tolerate any intake, vomiting, or mainly dry reaching. If you try to pass in as a gastric tube in their situation, it's remarkable that you won't be able to, because the stomach has totally volved either around itself, which is organovolvulus, or around its axis, the vascular axis, which is called the mesoaxial volvulus. It doesn't make a huge big difference. The mechanism is the fact that you've got 2 points that are more or less fixed, which is the pylorus and the gastroesophageal junction, and the stomach is floppy and it can roll around itself or around the axis of the blood vessels and its mesentery. Doesn't make a huge difference to the treatment. They both are surgical emergencies, and they both are treated in the similar way. So there is no much practical benefit of getting to differentiate between the two. Often you see the pylorus will appear in the chest above the level of the gastroesophageal junction. These patients will need immediate repair, an emergency surgery, and the process of the immediate repair and the surgery technically itself is no different from repair of the hiatus hernia that we mentioned earlier with the elective hiatus hernia repair. Thank you much again for attending to this lecture. I encourage you to subscribe to our channel. Encourage your medical student colleagues or friends to subscribe and leave us your comments or suggestions in the comment section, and I'll try and find time to address the queries that you have. Thank you very much. I will see you the next time.